talented rare disease patient advocate and rock star Grace Anto, who will be introducing herself and the second roundtable moderator today.
Um, Good morning, everyone. My name is Grace Antel, and I have frontonasal dysplasia syndrome with craniosynostosis. What this means is the right suture in my skull was fused at birth. I had a line down the middle of my face. My eyes were aligned, and I had a cleft palate. I've had 13 surgeries, including 2 skull surgeries, ear tubes, nose, mouth, and eye muscle surgery to help fix some of these difficulties. One thing I wanted to share with you is a quote that I coined: "Don't let fear take over happiness. Rare disease can be a blessing with the right attitude." So, the next session will be a rare disease policy roundtable. I'm happy you guys are discussing this topic because it is important. These decisions can lead to policy ideas that can improve the lives of kids with rare diseases. Please know that these policies affect children and families and have the ability to positively impact their lives. Now, I would like to introduce the moderator for the Rare Disease Policy Roundtable, Hugh Ewart. He is the Senior Director of State and Federal Government Relations at Seattle Children's Hospital. He currently chairs the Health Coalition to Children and Youth. Mr. Ewart, take it away.
That's the most memorable and most delightful introduction I've ever had. So thank you so much for teeing this up. I feel sort of like I should turn it over to you to moderate this panel. I'm definitely not as qualified to do this, but thanks again. And we're gathered here, as Grace mentioned, to really talk about policy and some of the policy options related to the rare disease issues. So we're going to cover 3 topical areas today. First, discussing the incidence and prevalence of rare diseases in Washington State and how better data collection and data could help inform collaborations within the rare disease community and with lawmakers and also with clinical providers. The second topical area is to focus on, as we've had some discussions in the earlier sessions, of course, some focus on the newborn screening panel in the state of Washington, and talk about how early detection can help dramatically alter the course of rare disease patients' disease management and their life trajectory. Third, we're going to focus on and discuss another topic that has come up in the previous session, rare disease advisory councils, and get into a discussion about how creating such a council could help advance the cause, how having a council, and I know other states do this, can help coordination between policymakers, families, providers, and researchers and others. So the structure of today's discussion, we have a pretty tight timetable. I'm sure we could go over, so we'll do our best not to do that. The first section, sorry, I should clarify, focusing on incidence and prevalence will be 15 minutes. And the second session, focusing on the newborn screening panel, will be another 15 minutes. And then the third section, focusing on, again, the rare disease, the creation of a rare disease advisory council, will be 7 minutes. We'll have a little bit of time at the end of all of this, 15 minutes, hopefully, if all goes smoothly, for some Q&A. And hopefully, and as well, we are, I believe, going to be joined by a few state legislators. So when I am aware of who is in the room, I'll make sure to mention that as well, and which state legislators from the state of Washington are a part of this discussion. So briefly, introducing the folks who will be leading the discussion, the experts here. For the first section, Syra Sultan, who is a policy consultant with the Haystack Project and also the president and CEO of Connect for Strategies, will be joined by Dean Sewer, who is the president and founder of the MLD Foundation. And I'll just go through, I'm going to do all the introductions now, and we can just roll through this as we get to it. The second section, focusing on the newborn screening panel discussion, will include two panelists, Jesse Conta, who is a colleague of mine at Seattle Children's, who's the manager of the PLUGS program, as well as a laboratory and stewardship program at Seattle Children's. And she'll be joined by Dylan Simon. Dylan is a newborn screening and diagnostics policy manager at the Every Life Foundation. And then finally, the third section of our discussion, which is the shortest in time, will be, the discussion will be led by Alice Patel, who is the state policy manager for the Western region for the National Organization for Rare Diseases. So those are the folks who will be the experts today who will be leading the conversation. We will have time, as I mentioned, for Q&A if all goes well, and we might be able to do that at the end of each of these sections, depending on how efficient we are with our time. So with that, I will turn it over to section one, first Syra and then Dean.
I'm sorry our CEO could not join us today, Jim Caro, although we are sad to announce that we're going to be starting a new CEO search soon. We're losing Jim. I am their policy consultant, so I'll make the first plug for Haystack's new CEO role if there are people listening who are interested. Haystack Project is an organization of 90 plus ultra rare patient organizations. I like to say we look behind the patient stories. So many conferences we all attend, we all hear about a patient story that patients were denied access or had an experience at the FDA or what have you. And, we all sort of move on from the story and get on with the policy and other topics we were covering at the conference. And really what we try to do is peel back the onion on what exactly led to that patient having the problem that they did. Is there a legal, regulatory, or just basic rules getting in the way of some sort of a systemic barrier for the patient? And we really focus on access, reimbursement, coverage, coding, payment, value frameworks, all these things that really get you through the FDA and you still can't seem to get access to the treatment itself. And why is that? We hold monthly calls. We have educational programs, health equity programs now, and a brand new payer program where we work with payer organizations, as well as a rare cancer program, and also a program focused on the work ICER is doing. So I'm going to talk with you today about the federal framework, and then Dean and the others, as Hugh mentioned, are going to get into more state work. But Haystack focuses largely on what's happening at the federal government level. The HEART Act is the first bill I want to bring to your attention, and I put prominently at the bottom, if anyone is listening and would like to reach out on that site at that place to email their congressman or senator at the federal level about supporting this legislation, that's the place to do it. And there are basically five, what I think of as simple, tangible things that if FDA were to do today would make the lives of rare disease patients better treatments to patients faster, because FDA would hear from patients directly and hear from rare disease experts. So anytime there's an advisory committee meeting on something rare, somebody with the expertise in small sample sizes is participating. Whenever patient input is required in assessing, you've got to talk to the patients about risk-benefit analysis for their population. It's not the same as it is for large population conditions or chronic conditions that are very common conditions. Also, rare disease expert has to be included throughout the FDA evaluation. And then to keep things accountable, we ask for an annual report to Congress of just how many rare applications each division at the FDA sees, because that will show us very quickly which division has a lot of experience and which division could use a helping hand from other rare disease experts at the agency. And finally, a GAO study that I hope will ring true for people like Dean on the call, where we finally get to see as patients, what is the difference between how EU does things and how we do things? I think our patient groups who are really active with the FDA are getting more and more frustrated that something is approved in Europe, but taking much longer here. So what are the differences? What are the tangible things in the process? Ultimately, all five pieces of in the Heart Act are meant to give us data, right? The idea is if we knew what each division's expertise were, if we knew what the EU was doing, if we knew what questions were coming up in the evaluation of risk and benefit, we could step back from anecdotal stories, I'm sorry, and get to data. And we often hear as patients that data is what we don't bring to the table. We bring our stories. And so we need to bring both. And we can't do that if we can't harness the data. And that's what this bill does for us. We are very actively talking with senior committee staff and moving the bill along as fast as we can. And we really, as we're going through this negotiation phase, could really use co-sponsors being added to the bill. So please, go to that link at the bottom of your page. The second bill that's also a federal bill is the Access to Rare Indications Act. I want to call out a stat article that just came out yesterday, I think it was. Amber Freed and her organization belongs to Haystack Project, a great piece on her and her child Matthew and how they're not able to get access to a treatment for them because it is not on the label and is not in compendia. As we know, almost everything is not on the label and not on compendia. And yet we, as rare patients, buy insurance policies or participate in Medicare and Medicaid, just like everybody else. And we deserve the same medically necessary care. But where do we go to find the definition of medically necessary? We go to the label and to the compendia. So we have this bill in Congress that says you have to look, Medicare and Medicaid have to look beyond label and compendia to find medically necessary care for children like Matthew in this article, like Grace, and so that they also get the benefit of the insurance they buy or the insurance they have, which is supposed to be medically necessary care. Here too, we are in deep conversations with committee staff. Some of the conversations get stressful, but I have to keep reminding myself that key staff are not spending an hour or 2 hours on the phone with us because they have nothing better to do. It's because they think we're onto something and we're just trying to shape the bill. So we've delayed reintroduction of this from last year while we work through some of the issues. But again, we get to work through the issues if there is strong interest in the bill. And that again requires co-sponsors. And what that means for us is that all of you as patients, as doctors, as clinicians, as caregivers, as parents, and then your whole community, your teachers, your babysitters, whoever you can lay your hands on, should be reaching out to their congressman and their senator, asking them to support these two bills. That's the work of Haystack Project. We have other bills in the Medicaid space. So as we transition to Dean now, I will just say that in Medicaid, a lot of the state-specific work around P&T committees, around what is accessible to patients in the Medicaid program, is also a big part of what we are working on in Haystack. They haven't translated into a bill yet, but the policies are being developed and talked about among Haystack Group members, and we hope to bring those to you soon.
Thanks, Syra, and thank you for inviting me to this session. And I do appreciate that we have a few minutes to talk here. So today I wanted to kind of connect the federal side of this down to the state side. Syra, I asked her to go first because I wanted to really dump in, do a deep dive right into the pond and let you know that there's policy and there's actions going on and there are people that are representing us in DC. And it's really important to engage with them, but it's also really important to engage locally. And I think you'll see the rest of this session is how we can balance that work out. I am a rare disease dad. 2 of my 3 daughters were diagnosed with a disease called metachromatic leukodystrophy. My wife and I co-founded MLD Foundation in 2001, in May of 2001, so we just passed our 20th anniversary. And you'll see my logo in the corner there also for another organization that I run, which is called Rare Army, which is really much more focused in the policy space. But I do this as part of MLD Foundation. I do this as part of Rare Army. And as we all know, there are many, many, many things to do. And I've just listed a few of them here, and you're probably overwhelmed with all of this, probably not the least of which is, we need a therapy. We need to have newborn screening, but you also need the policy to support that. And that's really important that you spend some of your time doing that. You're not lobbying, you're educating. So as nonprofits or as individuals, it's okay for you to do that. Incidence and prevalence, those two terms often get mixed up. Incident is the number of births, and it's usually the number of births per 100,000 or something, but you can think of it as the number of births. And prevalence is the number living. So depending upon what your rare or ultra rare disorder is, these numbers can track differently. So if you have adult forms of your disease, then you're going to have much higher prevalence numbers. If it's all infantile and those kids and those children only live a few years, then your prevalence is much lower, but your incidence may be high. So kind of keep that in mind when we're talking about those two things. So I want to just help you visualize the challenge and the opportunity. And sorry, I'm a little bit of an engineer, but this screen that you're looking at this on, and I know it's virtual, so a little tough to see, but it's about 2 million pixels, 2 million. The US population is 325 million. That's about 150 people per pixel, per every dot on this screen. So with metachromatic leukodystrophy, it's about, our incidence is about 1 in 40,000 births. Our prevalence in the US is about 1,900. We anticipate there's about 1,900 people alive. And I put a dot on the screen that represents in those 2 million pixels what MLD looks like. And I bet you can't see it, so I put a big arrow on it. If I go up to the umbrella, metachromatic leukodystrophy is a lysosomal disorder. We're one of 50 different lysosomal disorders. That's about 1 in 5,000 to 1 in 7,000 births, a prevalence of about 14,000. I put that same dot there. It's a little bigger. If you're having trouble seeing it, there's the arrow. But when we pull together as rare diseases and rare disorders, there's over 7,000 of these diseases. They affect 1 in 10 of us, of the overall community. That's not just in the US, but it's worldwide. That's about 32 million US residents. And that's how many dots, all those red dots there, are represented by rare disease. About 1 in 10, about 1/10 of the screen. That's a notable number, and I'm going to tell you why in just a moment. In the state of Washington, this is even a bigger number. Cancer, just for perspective, is about 1 in 20. So the number of patients with rare disease is about twice the number of patients living with cancer. So we have an opportunity if we can continue to work together. And again, thank you to Carolina and all the work that she and her team have done to pull this together. As we continue to build these relationships and work together, we're going to start to get increasing visibility. We have good visibility, but we need much more significant visibility with our policymakers. I always go back to this old artwork, and again, you can tell I'm wearing a little bit of a kind of an advocacy role here hat. 1 in 10 people have a rare disease. In the upper right-hand corner, you can see that rare diseases affect more people than AIDS and cancer combined. It's huge. We need to seize that and share that with people. But wait, if you take the patient, many of whom are children, over 50% of the rare diseases affect children. There are parents, there are neighbors, there's teachers, bosses, pastors, whatever, that are directly connected with that family and impacted by that disorder. And I would suggest that that 1 in 10 actually becomes 2, 3, or 4 in 10 constituents, adults, that can vote, that can move policy forward. So just round it off. What if it was just 3 in 10? That's how big that dot would be. 100 million constituents, voting people in the United States. Now we have some extensive influence when it comes to impacting policy. So when you think this is really tough, Cyrus started off saying, well, we need help here, we need help here, we need help here. If we can have 100 million people, we're going to be powerful. In the state of Washington, there's about 7.5 million residents. That makes 770,000 rare disease patients. That would be about 2.3 million constituents if 3 in 10 are directly affected. Voting, hopefully tax-paying constituents. In the November election, presidential election, just under 5 million people voted in the state of Washington. If all of the 2.3 million of us that are impacted by rare disease voted, we would have 47% of the vote in a presidential election year, even higher in other election years when the turnout isn't as high. So how do we engage those constituents? Some of the things that that I know that the Rare Disease Advisory Council and some of the other groups up in Washington, I'm in the Northwest, I'm in Oregon, so I'll talk about you versus me, but we're all in the Northwest together. One of the key things that you need to understand for the state of Washington, we'll do the same down here, is some about the population demographics. What makes Washington unique? Much like Oregon, You have several population centers. You've got probably 3 major population centers. But what makes up those population centers? What's the ethnicities? What's the demographics of where those people came from, or how they think, or what might be groups that might have higher incidences of some of these rare diseases? Native Americans, something we look at down here. We need to identify these, spelling error there, identify the patients and the families. There's a relatively small number of hospitals and specialized centers in the state of Washington. That means that data for rare disorders actually is concentrated in a handful of sites, but we need to have access to that. And one of the things that some other organizations are doing is ICD-10 code, which is the billing code that's associated with your specific disease, which can be rolled up into rare disorders. So maybe some mining of that data. I listed some potential starting policy areas. A number of these you're going to talk about, my panelists are going to talk about in the rest of this session. Newborn screening. Newborn screening has federal guidance, but it's a state public health program, and Dylan's going to tell you all about that. The Rare Disease Advisory Panel, really important to pull all of these different groups and information together. Medicaid, while it's funded partially by the federal government, it's state public health as well, and state policy. You need to be actively engaged in that. How do you get not just access to therapies, but reimbursement? In our disease space, over 50% of the patients are using Medicaid as a way of payments. We mentioned gene therapies, very expensive therapies compared to the kind of the regular pill you might get at a pharmacy. We have a gene therapy for MLD approved in the EU. We're worried about how do we pay for that under the Medicaid systems. And then another place where if you want to learn more, I'd just encourage you to get involved in Rare Disease Week, the Every Life Foundation. They have a program where they'll connect you with your local legislators as well as your federal legislators. So please get involved with them. I wanted to close with just one little quote and an engagement that I had with a big company up your way, Amazon. So I was talking with Amazon about Rare Army and some of their data services and those sorts of things. And I was talking about thinking outside of the box and the philosophy of Rare Army. And, they spoke back to me, and I think this is so important to us in the rare disease space, is don't think outside of the box. Think bigger. Think as if there was no box. We have an opportunity in a dynamic, changing environment for therapies, for policy, for people listening to the rare disease voice to actually come in and be creative and start new in some of these spaces. Certainly, we don't want to blow up what's there. We need to support and build from that, but we want to also move forward from there as well. So thank you. Look forward to the rest of the panel and questions as we have time.
Thank you, Dean, and thank you, Syra, as well. Before moving to the second section of our discussion, I just wanted to acknowledge and share appreciation and thanks for the 3 state legislators who have joined us. Representative Meelan Tai from the 41st District on the east side of Lake Washington, I should say. Representative Nicole Macri from the 43rd District, right down the road from us here in Seattle, and Senator Ann Rivers from the 18th District in Southwest Washington. Thanks to all 3 of you after a very, very grueling and historic legislative session for taking the time to join us in this discussion. I think in the interest of time, we'll move to section 2, and then as questions come up after section 2, from legislators especially, I want to be sure you have an opportunity to chime in with questions or comments as well. But I just want to make sure we stay on time here. So moving to section 2, which will focus on the newborn screening panel and issues around that. In order will be Jesse Conta from, again, my colleague at Seattle Children's at our lab, and then Dylan Simon.
My name is Dylan Simon. I'm the Newborn Screening and Diagnostics Policy Manager at the Every Life Foundation for Rare Diseases. And so I kind of want to start today to talk about newborn screening panel and the policy surrounding it and kind of go from a top down. And so Dean set me up perfectly earlier talking about how the federal versus state aspect of newborn screening. And it is very much a state-run program, but there is still a federal role. And so currently, in terms of policy, the big federal policy is the Newborn Screening Saves Lives Reauthorization Act. And that is currently being introduced in both the House and the Senate here in Washington, D.C. And we're hoping we actually see passage this session because unfortunately, the bill has been sitting there for about 2 years now, and the programs remain unauthorized. However, they are funded, which means that the programs are still running as needed, which is great. But again, newborn screening really is a state-run program, and the federal programs really are there to support those programs. And so a lot of it are these grant programs that help to fund the education around newborn screening, to help to ensure that the machines in the state labs have quality assurance funding. And so it's really the federal program, and the reauthorization is really how can the federal government best support the state newborn screening programs, because newborn screening is so state by state. It really varies based on what conditions they're screened for, how they decide to add conditions, screening fees, and all that really varies on a state to state level. In addition, one of the other federal aspects in which it tends to help the states is the Federal Advisory Committee. And so this is authorized through the Newborn Screening States Laws Act. And the Federal Advisory Committee stands for the Advisory Committee for Heritable Disorders in Children and Newborns. And it's really there to kind of look at the full picture of newborn screening. Because state newborn screening programs are working so hard to do the life-saving work of newborn screening panels, the Federal Advisory Committee provides the opportunity to look at it as a whole and really to investigate the issues and see where improvements can be made. And at the core of that is the RUSP, or the Recommended Uniform Screening Panel. So that is a list of currently 35 core conditions that the Federal Advisory Committee recommends that each state screens for. And so to get on the RUSP is a long process for which I would say we don't quite have enough time to get into today, but at its very short of it is a 5 to 10, 15-year process that culminates in submitting a package to the Federal Advisory Committee, and it's very much a science-driven, evidence-based process for that recommendation. And that process and the amount of people who submit to that, we are expecting will continue to increase in the coming years, which is where we get to kind of the state level work. And so us as a foundation, we advocate for what we call RUSP alignment legislation. And so what RUSP alignment legislation is it's really 3 parts. So it will require the state to screen for all conditions that are on the RUSP. Now, this is a minimum, not a maximum. If a state decides they want to screen for non-RUSP conditions, that's still well within their right. But currently, the RUSP is very much a goal. And what this does, it switches up and makes kind of the RUSP the minimum. In addition, it sets a timeline. So currently, it takes on average a state 5 to 6 years to add a condition following its addition to the RUSP. Now, as I just said, it can take 5, 10, 15 years to get on the RUSP. And so we believe that an extra 5 or 6 years on the other side of it is just too long. But at the same time, we do recognize that it does take time for state labs to add this. It is not a quick addition. And so typically it's about 2.5 years for addition. And that provides time for the state to raise the funds, to hire who they need to hire, to put in the follow-up structure so that when the condition is officially added, the state can probably screen for the condition. And the last part is funding. If we're going to require the state program, the state lab to screen for these conditions, we want to make sure that they have the funding necessary to do that. And this is a part that varies most state by state. And so with that, I do want to pass over to my fellow panelist, Jesse, but looking forward to you guys' questions today.
My perspective is as a genetic counselor by training at Seattle Children's. As you mentioned, I'm now in the laboratory, but I've been at Children's for 14 years. And so my lens is through the clinical perspective and how that impacts expanding newborn screening. And so certainly in Washington State, we're leading in some conditions. Recently, X-linked adrenoleukodystrophy was added, and we are leading in that, but not in others. So these conversations around expanding newborn screening are important. From my perspective, the evolution of our genetic understanding of conditions and then the associated genetic testing that can help to identify specific gene variants that are causing that condition has really resulted in a powerful tool and treatments for patients that are identified from newborn screening. And the timing and initiation of those treatments is critical. So having these conditions included on the newborn screening panel impacts the outcome for those patients dramatically. So recent additions to the panel have included cystic fibrosis, SCID, spinal muscular atrophy, And I've been able to see directly how positively that has impacted diagnosis and treatment for the conditions. And what's been beneficial, I think, is not only identifying the conditions, but integrating genetic testing as part of that rollout, because that helps us, again, not only identify patients, but also get to another level in terms of exactly what the cause is, and then to how we can tailor treatments. And that needs to be done thoughtfully. So it's based on our patient population. So as an example, when cystic fibrosis was added to the newborn screening panel, there was a thoughtful conversation around how to create a targeted gene variant panel specific to our Latinx population so that we can ensure through that screening process, we're really tailoring the diagnosis to patients and our local population and having the biggest bang for our buck. And so one other point that is important to consider, not only in terms of identifying and expanding the conditions on the panel, is the importance of aligning payer policies with newborn screening. So my day-to-day job is to help ensure access to genetic tests, and so that would include patients or children who are screen positive on newborn screen, but making sure that subsequent testing that's needed to confirm that diagnosis and to further guide treatment is covered and can be efficiently accessed by our patients, and we're not leaving folks with bills that could be avoided. So I know Dean touched on that a bit as well. So that's my perspective from the clinical side, and again, we're happy to take questions and further the conversation.
I'll just make another quick comment about newborn screening. So newborn screening, as I think was mentioned in the very first session today, has a couple of attributes that are very significant. One is it's done at birth, meaning it's pre-symptomatic or very, very early symptomatic. So that's when therapies are most effective. And so that's why there's so much emphasis on newborn screening. But another aspect of newborn screening that is critical is it is the singular place in public health with complete equity. Every baby is screened. Doesn't matter where they come from, where they live. If they come in the door and they give birth at a hospital or a birthing center, or even a lot of the doulas and stuff that give birth at home, they test those babies. So it is a truly universal health program, and that is where we can better understand. We can love on those kids and give them therapies, but we can also better understand what is the diversity of these conditions, what's the real incidence, and all of the dynamics and the genetic variations and those sorts of things.
Senator Rivers, did you have a question or a comment?
I do. I have a question for Dylan. I had a piece of legislation a couple years ago about a rare disease in Washington State and trying to make sure that it gets put on the panel and all of that. But here's my question for us legislators: which state does the best job? Which state has the best test panel? Which state is most responsive? And what policies do they implement? Do they revisit? You know what I mean? Is it a constant ongoing thing, or is it a one and done, check the box, now we can move on?
What I can do is definitely talk about some of ways that it's measured. Definitely, there are currently 17 states that screen for all the 35 core conditions. So that's a great metric to start at. Washington is one of them. So in that sense, you guys are leading. But the reason why it's kind of hard just to say one size fits all who is the best is because states have different priorities and different ways of going about it. For instance, there are Oregon and Massachusetts are hub states. And so because of that, they screen for the panels for multiple other states. And so it's not quite a like for like in terms of comparing them, but it's really where you see the most support. And that really varies, honestly. New York is one that often comes to mind, but that's because they also run a pilot study called Screen Plus, which plays a huge role in adding conditions to the RUSP. But going to your kind of how they go about it, our preference and what I just talked about is that RUSP alignment, which allows for once a condition is added to the RUSP, the state to automatically begin screening for. So, for instance, MPS II is currently a rare disease that had recently submitted their RUSP nomination package to the advisory committee. To do that, the National MPS Society spent a decade pulling that package together in terms of helping to fund the pilot, work with the pilot study, and bring all the information together. And that was a heavy lift for them. And once, if MPS 2 is added to the panel, they are then tasked with going to each of the 50 individual states to advocate to then add that condition to that individual state. And so our belief that's really at the core of why we advocate for this Russell Line legislation, because it takes that big effort outside of the patient advocacy organization, because they have spent so much time developing that package. And so that's why we look at it. Currently, there are 3 states that have passed that legislation. Knock on wood, there'll be 6 by the end of the year. And so those are really kind of our leaders in my end, but to say 1 or 2 are the clear best, I think is always a little hard.
And I would also add that you do not have to wait for federal RUSP approval in order to actually start screening for a condition. And one of the disconnects that you have in the state of Washington is that Professor Gelb at the University of Washington is responsible for the actual assay, the biochemical screening process for, I don't know, the last 4 or so conditions added to the RUSP. He's at the University of Washington, yet Washington is not as aggressive in some of these pilot studies, and particularly identified baby pilot studies. So there's an opportunity to increase your visibility, and then of course, as part of that, increase the connection with biopharma and all of the rest of that community to help move everything forward.
I want to make one quick extra point on Dean's point, because you're 100% correct. Dr. Michael Gelb is one of the leaders in the field, so utilizing him would be fantastic. But going back to the point I said in terms of each state is different. The RUSP line legislation does not want to say only RUSP, but we believe it should be the minimum. And then each state can then do their work to see, okay, what other conditions can we add on top of the RUSP? Working with Dr. Gelb is a place that you could potentially do that. But it's recognizing that each state is a little different, and identifying ways that you can build off of the RUSP to screen for conditions.
John Thompson from the Department of Health said that the Washington State is also a regional laboratory, and we screen for babies born in Washington State, Hawaii, and Idaho. So it's just a comment that he made on the chat.
Hopefully we get a little bit more time to get into some more of this discussion around newborn screening at the end of section 3. But I want to move to section 3 to make sure that Alice Patel has some time to talk about the explorations in the state of Washington among the coalition around rare diseases to look at the development of a rare disease advisory council.
So good morning, everyone. I'm Elise Patel, and I serve as the state policy manager for the Western region at the National Organization for Rare Disorders. And I really appreciate the opportunity to join you all today and share some information about NORD's Rare Disease Advisory Council work, why RDACs were started, and then some tips to hopefully help create an RDAC in Washington. And before we talk about RDACs, I just wanted to briefly share an overview about NORD. So NORD was established back in 1983 and was instrumental in the Orphan Drug Act, which created financial incentives for the development and treatments of rare diseases. And for more than 30 years, NORD has been working alongside the 300 plus patient organization members and has led the way in voicing the needs of the rare disease community, driving supportive policies, advancing medical research, and providing patient and family services for those who need it the most. So as many of you know, 25 to 30 million Americans are impacted by a rare disease, which breaks down to about 1 in 10 individuals. And while that's quite a few people that are directly impacted by a rare disease, what we're finding is that lawmakers aren't necessarily aware of the unique challenges that are faced by those in the rare disease community. And so the solution was to form a rare disease advisory council, councils in general, where diverse groups of those in the rare disease community could really come together and help advise state government. And this is especially important because we know that so many of our healthcare decisions are made at the state level. We also see RDACs as an enormous opportunity for the community and legislators to come together and partner in a more strategic way to address issues on a regular basis. And you might be wondering, well, what exactly does an RDAC do? So the legislation that's introduced includes a duty section, which will list out what each state will be working on. And RDACs typically seek public input to hear from the community about what needs to be addressed in their state. Some states have worked with consulting rare disease experts to help improve access and quality issues relating to health insurance, education, and treatment. And then they use these findings to help make recommendations to the legislature and other state agencies that work within the rare disease community space. We found that some councils have chosen to provide a list of publicly available resources on their state website, and have also used the RDAC as a way to research and improve the state screening program. NORD launched Project RDAC this past year as a way to help optimize the existing RDACs and also as a way to increase the number of RDACs across the country. And there are currently 17 states that have enacted RDAC legislation, with 3 states doing so since the launch of Project RDAC. And we're pleased to hopefully be adding Florida and New Jersey to the list very soon, as they're just awaiting their governor's signature. And under this initiative, NORD is providing opportunities for RDACs to collaborate with one another, which will include our upcoming RDAC Leader Workshop that we'll be hosting workshops that we'll be hosting in July. We're also going to be hosting a RDAC stakeholder meeting in September as well. And we've created toolkits as a resource to help guide RDACs for every step of their journey. The first toolkit that we created was called Creating a Rare Disease Advisory Council in Your State, and provides a step-by-step guide to building your coalition and determining what the purpose should be of the council in your state. Our second toolkit, which was released earlier this spring, is a comprehensive guide to the legislative phase of an RDAC and includes resources and tips on the legislative process, suggestions for engaging with lawmakers, and also advocacy recommendations for the RDAC once signed into law. And I welcome you to visit our website. If you go to rarediseases.org and click on our Project RDAC tab, you'll find these resources that we touched on, upcoming events for different coalition meetings for various states, as well as an interactive state map where you can actually view state-specific information. And then one of the resources that we've made available to those that are working on introducing RDAC legislation in their state is our NORD model language. And this has been adapted based on best practices that we've learned through existing councils. And it identifies the key components of a council, including RDAC duties, membership, where the RDAC will be housed, funding, and also accountability provisions. So the model language includes a variety of different duties that a council could tackle, and we suggest, focusing on just a few based on the needs of the rare disease community in your state. We typically recommend between 12 to 15 members that serve on the RDAC, with a diverse range of members to really include patients and caregivers, providers, payers, industry, researchers, and government officials. And this is important because we really want to make sure that everyone's voice is heard. Another component to consider when working to form an RDAC is to decide where your RDAC will be housed. And typically we've seen that most states house their RDACs within the Department of Health, but I've also seen universities and nonprofits as options. And while the funding of an RDAC really varies from state to state, and many actually didn't have any funding included as part of their legislation, NORD does recommend having language in the bill to allow RDAC members to solicit funding for the council. And then some of the accountability provisions that are recommended by NORD include listing the meeting requirements, opportunities for how the public can engage, and then what annual reports will look like. So being able to compile a report that shows what the council worked on that year, and then giving those findings back to both the governor and the legislature. And here's a map that really helps highlight the states where RDAC legislation has been passed, as well as states where efforts are underway to create. and RDAC. The first council was created in 2015 by some amazing advocates in North Carolina. And you'll notice that much of the progress has really happened over the course of the last 2 years, with I think 11 governors, I believe, is the count since 2019 being signed into law. And right now we have active legislation that's moving in California, Louisiana, Maine, Michigan, and South Carolina. And as mentioned before, we're expecting the governor of Florida and New Jersey to sign their RDAC legislation any day now. And if you're interested in learning more about rare disease advisory councils, please feel free to reach out to me or our NORD policy team, and you can reach us at rdac@rarediseases.org, or please visit our Project RDAC website, which is listed on this slide. And with that, I'm happy to open it up for any questions.
Hi there. This is Nicole Macri, and thanks for that, Elise. My question is, as you've worked on policy in other states to establish these councils, has there been pushback, or if there is any opposition to what's the nature of it? What concerns come up from policymakers?
Yeah, thanks, Nicole. That's a great question. I think, in general, that this has been a very bipartisan issue. We know that rare disease really impacts a lot of people. But I would say that, some of the pushback that we may get is regarding to funding. So based off what that looks like, I can give California as an example. I know originally they were hoping to not only get funding for a council, but also a rare disease ombudsperson. And as part of that process of moving it through, they had to remove the ombudsperson and just focus on the council. So I would say probably funding is the number one hold up. Yeah, but in general, I would say it's definitely an issue that we can rally a lot of support.
I have another question, follow-up Representative Macri questions. And by the informations of how we at Washington State serve as sort of a not regional, but for baby screenings for the other two states. So were there any sort of, because of funding as the number one barrier so far, are there any capacity as far as looking at regional effort? That is, state could come in together as partners in funding, at the same time building data that would provide and support necessary information for further understanding and legislations, because legislation for a state can be separate, but in terms of data building could be together. And so I'm curious if that was in your conversation.
Yeah, we really haven't examined the idea, like the regional idea, but I will mention, as part of this project, we're really hoping to have more collaboration among the RDACs. So I know that, we try to work and share information as far as what's worked well in some states, and some of the accomplishments that they've had, especially some of the earlier states that have, started since 2015. But I appreciate that perspective.
Thank you. And I know that I've been reached out by the group Pediatric Autoimmune Psychiatric Disorder, and I think they were successful in their legislation in Oregon as far as creating some awareness within the legislations. They have not been successful in Washington. So I'm curious if some of you are working with them, and whether they are in conversation with you as far as advising of how to lead an advocate for a successful legislative process.
Yeah, I'm not as familiar with, I don't know if anybody else from the panel wants to jump in on that question as well.
I can quickly say we haven't had an opportunity to engage with them, Representative Ty, but would look forward to connecting with you to maybe help make that that connection happen here after the panel.
What we're trying to do, I think, right now is in the Northwest with Born a Hero and this team is to build a coalition that has a couple programs, one of which is the Washington RDAC. So the fair is actually would be one of the programs to bring the community together, and we'll have a couple programs. because everything takes a long process. And so we're trying to, like, we can have the policy part, but also just the other programs that also take, have a process so that we can always kind of be moving things forward. But we are trying to sort of bring the community together so that we can create more and more awareness. But it starts with just, the collaboration and bringing everyone together. So we are working on that with that.
Great. I just wanted to chime in, if I could, with one more question on the RDAC for Elise. I'm wondering if you have any additional advice for those of us interested in the creation of an RDAC in the state of Washington as to what steps we should take and what considerations we should have.
Yeah, well, and I think that you guys are on the right track. I think that, the most important part is really forming a strong coalition and making sure that you have the voices of everyone that's part of the rare disease community as part of those conversations to really help develop, what does the council need to look like within Washington, and what are the needs that could be, tackled by an RDAC. So I think that's the first part, is just doing outreach and really taking the time to listen to the needs of those in the rare disease community.
I think the group is doing just that. So I had a question for Jesse. I was wondering if you had any thoughts or comments about the role of genetic counselors in the state of Washington, and whether there's anything policy-wise with our legislators here tuning in that could be pursued to help with your work in terms of diagnosing rare diseases, genetic conditions.
Certainly increasing awareness. We're really excited. The University of Washington has our first class of genetic counselors starting in the fall. So we have a local program which will set us up nicely to be able to increase access to counselors as we have more graduates coming out of that program. But in terms of tangible change that we need to see is what we observe is that for many tests, genetic counseling is a requirement in order to get the test covered. But then the counseling itself is not a covered benefit. And so there's actually federal legislation right now, the Access to Genetic Counselor Services Act, just to put a plug for that. This is HR 2144. And if you want to learn more, I'm happy to share, but support for that would really go a long way to ensuring access to genetic counselors who can provide support to patients to getting the appropriate testing and diagnosis and on their way to treatments. So thank you.
Yeah, thank you, Jesse, and thank you for raising that bill. I'm hoping we'll be able to share the various pieces of legislation, particularly the federal bills that we've heard about today from Dean and Syra and others to the group, so that those who would like to activate at the federal level have the opportunity to do so. I think I'm probably going to be, the old cane is probably going to pull me off the screen here in a second because of time. So I just want to say thank you so much to all the panelists for this discussion and for bringing these really critical issues forward. Thanks again to Representatives Tai and Macri and Senator Rivers for joining us. Really important to have such strong healthcare advocates in the legislature. We really thank you for all your work and your time, especially since it's now interim and you could actually be on a beach right now. And also, I just want to throw out thank you so much to the sponsors of this entire two-day disease fair, rare disease fair, and Caroline, all of your work. And behind the scenes, you may not have seen them, but this particular session would not have succeeded at all without the strong support of Max Brown and his team, and also Brittany and Rachel from Seattle Children's. So I just want to thank and recognize all those folks. And I think that's a wrap.
Yeah, thank you, Hugh, so much too for all your work. And yeah, everybody, I love having all the legislative working groups from all over the country represented here today, and to have an opportunity to hear from our legislators and have them here as we move forward to build this collaborative, with the Washington RDAC, and as and it's also, we're looking forward to working with our legislators to understand how we can best make progress on all these policies and move forward, like I said, with the Washington RDAC. So thank you so much for that.